possible. If we ever want, I mean, for two things. Number one, obviously, is the quality of care that we're giving to patients. Two is, in terms of marketing of this facility, to have the dementia unit is a big plus to people who are paying for or responsible for the care of dementia patients. But what they don't want to hear, and what they keep hearing from the government and medical societies, is that you don't want to warehouse these people by doping them up and keeping them on antipsychotics. I am not saying we're doing that, but in order for us to have a modified claim to be not only improving, but to be at standard, we do need a cohort that will be
or better than standard.
Or better than standard. And I think to the extent that we have a new medical director coming in, at least on a part-time basis, it may be a good time to re-examine this. This is to say nothing at all disparaging about Dr. Harm or his approach to it, but with every change, there's always a chance to re-examine stuff, look at things with new lights. But I do think we do have a research task, and that is to identify like facilities in terms of patient acuity and find out their uses, so we can make a valid comparison. We may turn out to be better, okay, but in order to have a valid claim, we need to have the data to show.
And to speak to some of your points, Larry, if you take a look at it, we're getting better. But if you take a look at the statewide averages, the statewide averages are coming down as well. And there's a big reason for that. When we talk about what were we doing before, you know, and what type of care were we providing before, we were providing the best care that we could, as well as all the other facilities. But what happened in the last 2-3 years is that the Department of Health and the state took on an initiative to reduce the number of antipsychotics. And so what they did was they started providing tools to the nursing homes to better be able to train staff and reduce the number of antipsychotics. And the fact that everybody's going down shows that the facilities are embracing that, and they are getting better with that.
I think in a competitive situation, we need to show that we're at or better than standard for comparable facilities. And it sounds like it's an ongoing effort. I think it's better for the population as a whole. We just have to be able to position ourselves in the forefront, or at least at standard or better, in the effort to do this. Because I think a lot of people, particularly the sons and daughters of elderly parents, are really paying close attention to that. They don't want to see, but don't mistake what I'm saying. There are people who, for their own safety and for the safety of the facility, need to be under medication. It's just that whatever that level is beyond that, we should be as parsimonious as possible in our use of that stuff.
So I assume the state has those types of measures already identified for your baseline?
I think it might be just a question of trying to identify, you know, a cohort of comparable facilities that have at least dementia units and have dementia units that are of, in terms of their percentage of patient mix, something within ours. Take a look at their statistics and see how they rank.
Yeah, I think we can go out on the PACA-1 list and go and survey facilities that are county homes that are taking the same types of residents that we take, you know, because in many instances we become the facility of last resort, you know, for that tough resident, because nobody else will take them, so the county ends up taking them, because that's our mission, you know, is to take care of the most needy people in the county.
Are you saying your baseline will only be made up of publicly owned?
I think that it would be more accurate to take a look at publicly owned facilities and then narrow that down, and then take a look at publicly owned facilities that have dementia units, and then take a look at both sets of data.
I would think it would be good to have anybody who has a dementia unit at a certain level of significance. Clearly, we don't want to go up against, compare ourselves up against a country club place where the biggest injury they're dealing with is tennis elbow. Okay? What we want is private, public, or in between. If you've got a dementia unit that, say, you have 10% of your population and your facility is in this thing, then we should be able to compare ourselves. And the fact that if we're under such big competition with private facilities, if we're doing the job as well as them or better, at perhaps a lesser cost or whatever, all the more reason to bring your
From a marketing standpoint, I think it would be better to have that larger universe, but the ability to break it out specifically by publicly owned certainly would be useful knowledge
Yes.
for a management standpoint.
We'll research it for you.
Did anybody else in here know who Manny Young was?
Yes.
All right, good. Did anybody else know who Penny Youngman was?
Oh, yeah.
That's a way to date yourself. Not everybody knows.
So we talked about internal marketing as one of the first things we're doing. We're in the process of setting up an internal marketing program. A marketing committee can be made up of the people on the right, administrator, DON, CFO, maintenance, somebody from the union, CNA, activities, quality assurance, and then others as needed. You might want the medical director to sit in on a meeting where, we're going to be talking about different types of services, clinical services that we might be offering. And we want to get focus on the outside, the inside of the building, and the services and the programs. This marketing committee will not drive our marketing campaign. They are part of our marketing strategy is to make sure that we are that our stuff is together as from the perspective of somebody that's coming in and viewing our facility. Maybe it's putting together a customer service program for our employees. If that's what we feel like we need to do, then this is the committee that would drive that.
That's chaired by the nursing home administrator.
Correct. He just doesn't know that yet.
I've done it before.
And then external marketing. Hospitals are by far our primary feeder, and we need to have outreach programs. We talked a little bit about that to get the community into Claremont, and we're in the process of doing that. We will describe some of those. And then again, in keeping with our strategy, we want to position Claremont as a geriatric expert in Cumberland County. That may be, as simple as developing an Alzheimer's support group and offering it to the folks, getting those folks into the building. Maybe it's a grief support group. There are a number of different areas, where there's probably a need for these types of programs that we certainly have the talent and the expertise where we're able to do it. We need to expand our non-exclusive insurance utilization. And Lynette has been focusing on those areas diligently. We need to put more work into that. There are a number of them that we can put into place that we currently don't have, or we don't have high utilization in. United Health is one. Geisinger, correct me if I'm wrong, Lynette, we don't have a contract with Geisinger because they're full up in the area. We need to go to them and we need to, again, show our metrics. We need to show them what a good job we're doing and tell them that they're actually missing an opportunity by not using our facility because our metrics are better than anybody else in the area. And that's the strategy that we'll employ with them. Humana, Vibra Health, and the VA. We get a few VA, but we don't go out and visit the hospital in Lebanon. And so we're in the process now of going back out and visiting the VA. The VA isn't your best payer, but it certainly pays every month and it fills the bed. So we need to stay neutral. We don't want to have exclusive arrangements with any hospital, and we need to work to improve our referral rates because our outcomes are to the point where we need to improve our referrals to improve our admissions. The more referrals we get, the more admissions we'll get. And then we need to exploit every marketing opportunity with referral source. To give you an example of that, we need to become more user-friendly with them for managed care. When somebody is in the hospital, the case management staff is doing the pre-auths to get them authorized for nursing home care. We can be doing that for them. And so, again, the easier we make it for them to do their job, the more likely they are to send us more referrals. Our primary feeders are 3 hospitals primarily. Our 3 sources, Pinnacle, made up of Harrisburg and West York, Holy Spirit, and Carlisle Regional. So those are, you probably get most from those 3 places. So we've developed a strategy for working with the 3 hospitals. It's a little bit different. It's a little bit the same for each of them. But this is what we are going to be doing. Helen Schultz, our marketing person, is going out and she's visiting Holy Spirit 5 days a week. So we're out there every day. And if in fact we can pick up somebody that needs to be looked at to make a decision on whether to admit them to the facility, then she'll be there to do that. We're introducing Raymond to the key management executive staff on September 25th. So we'll get him in front of them so they'll be able to put a name with a face. We think it's easier to work with them if we've got some type of a personal relationship built with them. So that's going to be the first step in doing that with Raymond. We're looking to recruit a physiatrist for rehab, and we talked about Dr. Buccanacci, and he's going to be meeting with you in the near future. And then we're going to meet with the case managers and give regular updates on our facility metrics, okay, on our outcomes, how good a job we're doing. We can show that. The data doesn't lie with us. At Carlisle Hospital, a little bit different, a little bit the same. We've got a joint marketing effort that's beneficial to both organizations. We're going to be having Dr. Mira presenting a program, an orthopedic program, on different types of orthopedic procedures that are being pioneered. And he's going to be talking to a community group, and that's being marketed by Claremont as well as Carlisle Hospital. So we're partnering with them in this area. Helen is at Carlisle Hospital 5 days a week. And then Dr. Oliverio, who is a representative of OIP, he's an orthopedic surgeon. We have him coming out to visit the facility, bring his PAs, and we hope to get him on board with us. And I think I told you the story that we were at a chamber mixer, and he was talking about how they don't take hips and knees in rehab units anymore. But when he sends them to a SNF, they don't get enough therapy to get them better. And so we wrote him a letter and detailed out that we would give their patients the same amount of therapy that they would get on a rehab unit if they came to our place. And when we sent him that letter, told him we had 7-day-a-week therapy, then he said he wanted to come over and take a look at things. So again, it's looking at the opportunity and taking advantage of it. So we're working on introducing Raven to their key management staff. We're going to meet with the case managers and give them regular updates on the facility metrics and recruit a physiatrist for rehab. Then at Pinnacle, this is a little bit different than the others. We're going to work to become a preferred provider in the River Health ACO. And that ACO is a accountable care organization, and they manage the lives, so they go at risk for the lives that they take care of. And so 20% of Pinnacle's admissions to the nursing home are from that ACO. But if we become a preferred provider, then that number will go up. And so we have been working with them in a non-exclusive arrangement to show them our metrics and become a preferred provider. When they initially set up the ACO and they were in their infant stages, what they did was their preferred providers became the facilities that they admitted the most residents to, which we feel is ludicrous. You should be admitting your residents to the facility where you get the best outcomes. And so that's what we've been impressing upon. And so we're starting to have some movement in that area. They want us to help them track their residents. So we're participating in the patient pain, and it's a tracking program for their ACO residents. So it's not much work for us, and again, it makes it user friendly for them, where they're able to know when they come in, where they go, when they get discharged. If they go to a hospital and it's not Pinnacle for some reason, then they know which hospital they went to. That's the type of data that they want to gather. We want to recruit physiatrists for rehab and then meet with case managers. Now our rehab admissions, our skilled admissions, we have increased, and our skilled admissions are up by 43% when we compare 2014 to 2015. And since transitions was opened in March, our skilled admissions are up by 71% when comparing lifetimes from 2014 to 2015. So we are getting skilled admissions. And again, on length of stay is problematic. It's good that we're getting a great outcome, but it's bad financially because we're not keeping the people as long as we had projected. So it's easy. We have to work harder to find more appropriate rehab candidates.
What do you mean by that, John?
Well,
I mean, these folks are coming in, and because of the great job we're doing, the length of stay is shorter than we had projected.
Right. Right here, if you look at this next slide,
Okay.
we need to expand that circle to secondary markets. So we've got 3, primary feeder sources. We need to expand it. We need to get more residents from secondary. Our circle needs to be bigger. We need to go into the Harrisburg market. We need to go into LTACs, long-term acute hospitals, which are like ICU units for senior citizens. It's just a different type of an acute care hospital. And so the Select Specialty Hospital, they have at their Camp Hill location inside of Holy Spirit, and at Harrisburg inside Harrisburg Hospital. It's a hospital within a hospital is what it is.
These are specifically the Select Medical Corporation facilities.
Correct.
Okay.
Yeah, we need to target them. The other LTAC is Life Care Hospital. We can't.
The goal, though, is still the transitions, is still short-term rehab, right?
Correct.
We're still going to be, essentially working to get the patient
Because
home as soon as possible.
the average length of stay for LTACs is what, 25 days, 29 days? 29 days is, that's, in order to become an LTAC, you have to have an average length of stay of 29 days. Okay. People that are in those LTACs and they're on their back, taking care of various comorbidities, they become very deconditioned. So they need a bout of therapy in order to get back up on their feet and go back to where their previous living arrangement. And that's where we see the synergy between the LTACs and the rehab.
So the premise is if we retool our formula, the original formula said we will be at a good point based on number of patient referrals for rehab times the length of stay gave us that number. Now, we have retooled per our previous discussions, per your previous slides, given that our length of stay is shorter, in order to optimize it financially, we need to bring in more rehab patients at a faster rate than we originally anticipated. So what I think John's trying to do here is, where could we get them from?
Okay.
And then we'll go on to how can we actually get it.
Right. So we need to do a better job of our three-wheel.
We're still focused on that, on the Medicare.
Yes. We are.
We just need more.
We need more. Then Helen M. Simpson Rehab Hospital, Penn State Hershey Medical Center, Tertiary Care Center. I don't think that we get as many residents out of there as we possibly could. They have a rehab hospital there. And in order to do this, in order to expand that secondary market, it may require an investment in additional marketing case management staff to put them out there in those areas to beat the bushes and to get good, solid rehab cases. So what I'm proposing is that we expand our marketing case management staff and employ an RN to visit hospitals. And what this RN would be, she would be, this person would be empowered to go out there and make the decision on the spot whether to admit this resident or not. So they would be in the hospital, reviewing the records, meeting with the case management staff. And my goal is that within 10 minutes that they're able to make a decision on bringing that resident into Claremont.
So the one issue I would take with this is that if you talk about using funds saved in another area, i.e. outsourcing, that makes this new position a cost center. What we want this to be is a revenue generator, self-sufficient. I think the terms for evaluating whether or not the pilot is successful is, can this person and their salary and their cost overall generate enough new referrals to pay for themselves, regardless of savings in other places? Because CNRC is a big enterprise, and whatever savings we make any place, there are probably lots of places where they could go. This one in particular, because it's a marketing recruitment position, should be a revenue center rather than a cost center, and should be evaluated on that basis. Now, it may take time for it to ramp up. We give it some time, some incubation time, but I think that's the basis that we would have to evaluate its success over whatever period of time.
We projected that we'll save approximately $200,000, if we would outsource the departments that we've talked about in the past, housekeeping, laundry, and dietary. And so that's how I would propose to pay for it.
And what I'm saying is I don't think we should do it that way. I'm saying that what we should do is basically put this position out there, take it out of our existing administrative. It's hard to earmark any savings created by anything until A, that they're achieved, and B, that you know how they're going to get distributed. But I think we view this thing as, again, it needs to pay for itself after a certain period of time, or it has to give indication that it'll pay for itself and be not only self-sufficient, but bring in net additional revenue.
That should be easily measurable as well. It's just a matter of how much time period you want to give them to essentially.
Right, so for instance, you bring in this new person, Helen, let's say Helen, if it sounds like we're going to clone her, because she's 5 days in one facility and the same 5 days in another facility, she's traveling a lot. So let's say we have Helen doing our 3 biggies, 3 in Carlisle. We can, and we hire a new person to go out and do the stuff at Hershey and all the other places that John outlined. Any referrals that we can get from those facilities, we can assume and attribute to this new person doing this stuff. And once those relationships are established and you have a referral flow, it begins to generate its own momentum. And if people are satisfied with the service we do. So it's an investment we would make, but it should be an investment with a projected positive rate of return on whatever monies we use to pay for.
And you would need to have an RN to essentially do what you're thinking about doing.
The RN with good assessment skills would be the ideal candidate there, so that they can go through, they can take a look at the record, they can talk to the case managers, they can review the medications, they can make sure that this is somebody that we can handle and make the decision on the spot. They're empowered to make
get your 10 minutes.
Absolutely, in 10 minutes. That's our goal. The other piece of it with Helen, go ahead.
I'm just asking, we have folks that work for our office paging that do assessments as to whether or not someone is, eligible for, nursing home care, and they're not RNs. So my question is, what's the difference? This is, of course, for rehab, I guess. Maybe that's a different situation.
Well, they're making a determination as well as on the finances of somebody. You know, if they see a chemotherapy drug, somebody from aging, they may not know, they may not care what that chemotherapy drug is going to even cost. However, I would expect that our nurses going out there, they would be familiar with it, and then they would be able to say yes or no on whether this is a winner or a loser for us.
I'm just, my question is, I agree with the idea in terms of, having somebody that can, sign all the papers and get everything done and all that, make it work to attract greater admissions. And I kind of agree, I think, with what Larry said relative to this. If we're going to make this investment for recruitment purposes, then it should pay for itself. But so anyway, I was just asking relative to the question about the qualifications for this position.
The second piece of this is, and we've agreed internally that we're going to stretch ourselves. We believe that if we put somebody on here, pilot this thing, maybe put somebody on half-time, to pilot the program and see if it works. If it works, we expand it to full-time. But if we're getting more admissions, we probably need to have more admission staff. It doesn't do me any good to be getting all of the referrals if we don't have time to process them and admit them. And so I see on the back end that we may also need to expand our admission staff at some time by a half a person or realign some of Helen's duties so that she's able to participate more in the admissions process. Right now she's strictly a backup. But I foresee if this program works the way I predict it will, then we're going to need to have more admission staff as well.
You're looking at like social workers?
Not necessarily a social worker, but somebody with a background similar to that would be all right. And then from a clinical perspective, we've been on-site support for all complaint surveys by Department of Health, by our clinical associates. So we've probably had 2 or 3 complaint surveys since we've been here, and my nurse, Sherry Hoffman, she's come out and supported the facility in those. ICD-10 training, which is a medical coding system that is being overhauled and revamped starting October 1st. We conducted training for it. We recruited a nurse practitioner for Claremont, where we had a physician that retired. We felt that we needed to have a female presence in the building to take care of staff, and so we were successful in recruiting a nurse practitioner. And then, you know what happened at the beginning of the year? Our 5-star rating dropped, and we've been working to get it back. We've been actively working with our pharmacy consultant to focus on antipsychotics, and you can see the result. It has been going down. Remember that we had that issue with the RN staffing where we had a number of holidays where we had RN staffing that was off, and so it caused our rating to go down. So we have a plan now over the holidays to release staff so that we wouldn't take as big a hit as we took last year. And then we just recently finished our mock survey, premiered it with the facility. And so we need to use that mock survey as the work plan to get ready for the survey, because if you remember when we talked about this, it's the annual survey that really drives the 5-star rating. If you don't get a good annual survey, then you're not going to have a good 5-star rating. So it's imperative that we work diligently to do that. Raven has the mock survey results. We met with the staff today. We've been over it with them. They all have it in their hands, and so they're going to be working on a plan of action to correct the deficiencies that we cited.
And that's going to be presented, I guess, at the next review, CNRC review.
Yes, we'll review that.
Raymond, do you have any thoughts at all?
Well, I mean,
Nothing like putting him on the spot.
Hey, he's still here, he hasn't left.
I think we're definitely moving forward. I mean, many aspects that we're talking about that we need to have in place are ones that I've had in other facilities that I've worked in. Specifically, for example, the case manager. I mean, they're there in the hospitals waiting for those referrals. And they will plant themselves at one hospital at this time, and at that time, they even go in specific times just to know to get the most referrals for the day, and then we'll help and assist and do everything they can. It's very competitive out there, so the idea of having a case manager would be great. Now, I know you did make a point about, oh, does it really need to be a nurse? Absolutely, and the reason why is because of the different diagnoses, the medications. If we're going to carve out certain medications because of the cost being too much and eliminate that referral on the onset and try to get the best type of candidate for us, you know, we definitely would.
Okay.
That would definitely be a big plus on our side. It's going to move us towards more admissions and tons more referrals.
The other thing that the RN brings is it brings some credibility with the hospital, okay? And so I think that's what they expect to see. Be able to talk to somebody in medical terms and not have to explain it to them.
And I was at Carl.
So what's the difference, that's okay, so what's the difference between, you know, Helen's mission and, you know, what you're, you know, anticipating here with the
Good
other?
question. Helen goes to the hospital and she has a limited range of knowledge about the clinical aspects of the care. She gets into a bind, she's calling somebody. She's calling Lisa. Lisa's in a meeting, so she's trying to get a hold of somebody else. And so she may not even be able to contact somebody and get the answer, okay? So then Lisa ends up with 2 more questions that she has to go back in and go into the record. And that's what we're trying to avoid. You know, we want to make sure that somebody goes out there, they've got good clinical assessment skills, they can take a look at the record, they can put an eyeball on the patient, and then know whether this is.
So then are you looking at like Helen's assignment here as kind of like an interim, kind of like a assignment until we move toward your end?
I see Helen's role changing. There are, because I have her backing up admissions, doing the marketing, like the brochures, the collateral materials and stuff like that. And then she's going out 5 days a week to the hospital. She's spread very, very thin.
Oh, yeah, that's what I was thinking when you were
right.
talking
So
about.
I see her.
2 places at 5 days a week,
right.
Plus everything else.
Right. I see her being more focused on the marketing aspect of it rather than the patient finding. Okay, and let that up to the clinical person to do that. And then I see her working on the brochures, how do we get this into the pharmacy, you know, that type of thing, as well as backing up admissions more than she is right now, because I expect that the admissions will increase.
Okay. So this is, it is kind of like an interim situation then relative to
Yes.
at the 2 hospitals for Helen's visits.
Yeah.
Okay.
Any questions, comments, observations? Okay. Well, thank you very much.
Thank you.
Appreciate it.